of movements which are possible at temporomandibular joint and what are the muscles producing the movements. Because if the joint is asked, obviously muscles producing the movements will be asked along with it. Okay, so do like this: depression, elevation, protraction, retraction, and side to side swivel. Okay, these are the muscles we have. So dislocated jaw. See, the clinical way of framing question is sometimes if the ligaments surrounding the joint, suppose if they are not working like properly or if there is any damage, so when we do yawning overly, sometimes it may get dislocated. Okay, so that is dislocation of mandible, which is actually you can see here. It is forwards. It is supposed to be in the mandibular fossa, but you can see it has moved forwards in forceful opening of mouth. The dislocation is treated by elevating the chin to throw the head of the mandible in proper position. Okay, so that may be actually like framing of question, like there may be a dislocation where person was yawning very much irregularly and you can see the jawbone has got dislocated. What is the condition and describe the joint? It may be something like that, the framing of question. Okay, and this is the way it is again brought back. Press his premolar teeth downwards, at the same time press the underneath of his chin backwards and upwards. Okay, so that is all about this temporomandibular. Okay, portal vein. So how is it? How is this portal vein formed? Let us see. So first of all, the portal vein is formed by the combination, like the splenic vein is actually joining with the superior mesenteric vein. So both these veins will join to form the portal vein. Okay. So we know like this portal vein will enter into the liver, and finally you will see it will have so many ramifications, and the venous blood from portal vein will drain into inferior vena cava. So because we didn't do arteries first, basically from abdominal aorta we have three arteries. The artery of foregut is celiac trunk, the artery of midgut is superior mesenteric artery, the artery of hindgut is inferior mesenteric artery. Corresponding to that we have veins. Now see here, into this splenic vein you will see inferior mesenteric vein is opening, and this is the superior mesenteric vein which is joining the splenic vein. So both of them are like joining to form the portal vein. So if you observe this picture, this portal vein is actually collecting the venous blood from almost all parts of the GIT. You can see stomach, small intestine, you can see large intestine, rectum, anal canal. So overall, for all parts of the gastrointestinal tract, the venous blood is now being collected by portal vein. This portal vein will be rich in nutrients. Okay. So now let us see portal vein. Now whatever is shown in blue color here, that is portal vein. It is formed in front of the inferior vena cava. Whatever has been shown in violet color here, that is the inferior vena cava. So portal vein is formed in front of the inferior vena cava and behind the neck of the pancreas. Okay, the length is around 7 to 8 centimeters and it doesn't have any valves. Okay, the like it is coursing, like from the lesser curvature of the stomach we know like we have lesser omentum, isn't it? So it is moving from the like right free border of the lesser omentum. Okay, so now see, this is our portal vein. It has entered into the liver. So many ramifications are there, branches are there. You see, that means portal vein is carrying blood to the liver, which is rich in nutrients. Though it is vein, but usually a different color will be used to represent portal vein because it is carrying the blood rich in nutrients. Okay, like the end products of digestion, like we have glucose, we have fatty acids, we have amino acids. Glucose will be converted into glycogen and stored in the liver. Fatty acids will be converted to glycerol and stored in the liver, and so on. So like from these ramifications you are finding the hepatic veins are forming. So these hepatic veins will drain into inferior vena cava. Okay, so liver receives 25% of resting cardiac output through this portal vein only. Hepatic artery is carrying 25% of the blood and portal vein is carrying 75% of this 25%. Okay, so it is actually carrying blood from the GIT, which is rich in nutrients. Okay, then blood is living via hepatic veins. That means entering through portal vein, living out through hepatic vein, and the hepatic veins finally they will drain into inferior vena cava. Okay, hepatic veins they will drain into inferior vena cava. Okay, see the entry: portal vein, splenic vein and superior mesenteric vein will join to form portal vein. From portal vein the blood will go to hepatic vein. From hepatic vein the blood is going back to inferior vena cava. Okay, so the course of this portal vein is divided into extrahepatic and intrahepatic. Extrahepatic in the sense whatever you are seeing outside the liver is extrahepatic. Its course, whatever you see inside the liver, you call it as intrahepatic. So extrahepatic, the length is 8 centimeters and width is 2 centimeters. Okay. So then uh, so like portal vein, you can see its course, it is directed upwards and slightly to the right. See, where is it formed? Behind the neck of the pancreas. See, this is head, this is neck, and this is body, and this is tail of pancreas. We will replace pancreas as essay with some repeated question when we do paper 2. Okay, if any repeated question comes, because pancreas is also an essay question. So at the neck of the pancreas, you will see behind the neck of pancreas, the portal vein is running and it is going behind the first part of the duodenum. So this is our portal vein. We know this is the lesser omentum. This is the right free margin of lesser omentum. What is the communication point between the greater and lesser omentum? Like greater sac and lesser sac. There is a communication. Epiploic foramen, isn't it? Foramen of Winslow. Area in front of the greater and lesser omentum, I told you greater sac. Area behind the stomach and lesser omentum and greater omentum, I told you, is lesser sac. The communication point you see at the right free margin of lesser omentum, you call it as epiploic foramen or foramen of Winslow. So at this point, you are finding three structures. You can remember as VAD, VAD. We see portal vein, we see hepatic artery, we see bile duct. One is green in color, one is red in color, one is blue in color. These are the structures we see in porta hepatis of liver also. Same structures. They are actually passing from porta hepatis, moving along the right free margin, and then they are going towards the destiny. Portal vein is crossing the right free margin and entering into the porta hepatis of the liver to enter into the liver. Okay. See, this is our portal vein. You can see this is right branch and then this is the left branch. Right branch is going towards the right lobe and left branch is going towards the left lobe of the liver. Okay. So extrahepatic part, if you want to see the relations, duodenum is cut. Basically, duodenum has four parts: first, second, third, and fourth parts. First part is not shown here. So it is seen like right in front, you see the neck of the pancreas. Behind, if you cut the portal vein, we will see inferior vena cava. Okay, and on the right side, it is related to bile duct. Okay, retroduodenal, same like bile duct, what we studied yesterday, it also has same relations. Retroduodenal means the part which is present behind the first part of the duodenum. Okay, so it is related to gastroduodenal artery on left side and posteriorly it is related to inferior vena cava. Supraduodenal part. See, this is our first part of the duodenum. This is our portal vein, and this relation is above duodenum. You call it a supraduodenal part. We know it is situated in the right free border of lesser omentum, where in front it is related to the bile duct. Front and right, you see the bile duct. Behind, always you remember we have inferior vena cava only. Throughout its course, we have inferior vena cava. Okay. In front, it is related to hepatic artery. Okay, in front and to the left, right bile duct, left hepatic artery. Okay, behind inferior vena cava. Okay, these are the three simple words which you can remember. So this is porta hepatis area, which we see on the inferior aspect of the liver, where we have VAD structures. What are those? VAD. V is portal vein, A is hepatic artery, and D is bile duct. VAD structures we see in the porta hepatis. Okay. The intrahepatic part. Intrahepatic means now it has successfully entered inside the liver. It is dividing into right branch and left branch. okay, which is coursing. Right branch is going into right lobe of the liver, which is shown in light blue color, and left branch is moving into this yellow, whatever color it is moving like this, okay. Then, so the portal circulation, you see the portal vein has started and it has entered into the porta hepatis, and in the liver it is dividing into right and left portal veins. They will actually enter into the hepatic sinusoids, which when we saw the histology of liver, I have shown you the sinusoids. Okay, in the center of the hexagonal hepatic lobule, we will see central vein. From there, the venous blood is collected to sublobular veins. From there, finally, the blood is now collected to into hepatic veins. From hepatic veins, the blood will be finally collected into inferior vena cava, IVC, inferior vena cava. So the portal system includes all the veins which is draining the blood from the abdominal part of the gastrointestinal tract, except for the rectum, lower part. Okay, it is collecting all venous blood from the GIT, okay, including spleen, pancreas, and gallbladder. Okay, so from here, once it goes, these are the hepatic sinusoids it branches into. Okay. So portal system, in the sense we have set of capillaries in the liver and set of capillaries in the intestines. That is the meaning of portal system. Okay. Set of capillaries we find in the liver and set of capillaries we find in the intestine. And the connecting channel is portal vein. It is something like a port which is connecting the capillary network of one side to the other side. Two set of capillary networks. That is the meaning of portal vein. Okay. Then now let us see, this slide is very very important. We should know what are the various veins which are draining into this sky blue color vein. We know this vein is a portal vein. So into this vein, we know this vein is draining. What is this? Splenic vein. Okay. And next vein you are finding, this is actually pyloric vein. Okay. Then we have superior mesenteric vein. This is superior mesenteric vein. Okay. Cystic is actually coming from the gallbladder. Okay, we have cystic vein. Then right and left gastric veins are this. This is left gastric vein. This is right gastric vein. That is also draining into portal vein. And around the umbilicus, we have veins, you call them as paraumbilical veins. So many veins are draining into portal vein. That means these are the veins which are collecting blood, and finally the blood is poured into portal vein. Okay. Then, so this is the same slide you have again. Mm, So once you know this tributaries, you should know. So now we will try to learn porta-caval anastomosis. What is the meaning? This itself can come as a 5 marks, or essay itself may be framed in this way. I will tell you the clinical aspect, then you will know how the question will be framed. Porta-caval anastomosis means this light blue colored vein what we have is portal vein, isn't it? Just a minute. See, porta-caval anastomosis meaning is the portal vein and inferior vena cava, they are just forming a network. That's what is called as portocaval anastomosis. Portal vein and inferior vena cava. They form a network in various parts of the body. Like you are finding one network is found at the esophagus. Number one is written. Number two is you are finding sky blue veins and this violetish veins. Violetish veins are inferior vena cava tributaries. Sky blue veins are the tributaries of portal vein. The junction of these two veins you call as porta caval anastomosis. One you are finding at esophagus, one you are finding in the posterior abdominal wall, one you are finding at the rectum anal canal, one you are finding around the umbilicus. Like that, we have many areas where portal vein and inferior vena cava will form a network. You call it as portocaval anastomosis. Okay, so let us see where we see this. Esophageal anastomosis, the azygous vein, we have studied yesterday or day before yesterday. Azygous vein is a tributary coming from inferior vena cava, and left gastric vein is the tributary of portal vein. Both they form network at the esophagus. That is esophageal anastomosis. Around the umbilicus, we have epigastric veins, which are the tributaries of inferior vena cava. Paraumbilical veins are the tributaries of portal vein. So they form a network, that is paraumbilical anastomosis. Rectal anastomosis. One is sky blue color, that is portal vein tributary, that is superior rectal vein, and other is you are finding violetish blue, that is inferior and middle rectal vein. These are the tributaries of inferior vena cava. So that is third anastomosis, that is rectal anastomosis. Again, there is a table in Chaurasia. You can share, Niharika. Porta caval anastomosis table is there. You can learn that. Then retroperitoneal anastomosis is something which we see behind, like number 2 it is. So like retroperitoneal parietal veins we have there. So porta caval anastomosis. I hope you understood the meaning. Esophageal, rectal, paraumbilical. Now see here, suppose if there is any hypertension, whenever the blood pressure is increasing, so what is happening? I'll take you with simple picture. You just don't read anything. See, suppose if there is any hypertension, especially hepatic, suppose if liver is not working properly, then you will come across a condition called as portal hypertension. Due to liver failure, if blood pressure rises, you call it as portal hypertension. So in case of portal hypertension, the umbilical veins, no, they expand, they become very much tortuous, okay, around the umbilicus, and they will be seen like caput medusae. That was the picture. Now you are finding the paraumbilical veins of the portal vein, and also from the caval veins, they are all fanning out, and they are forming this type of condition. You call it as caput medusae. Caput medusae is a condition what you see when we have this type of damage. Okay. In case of portal hypertension, we find this type of clinical condition. So this is one condition. Esophageal varices. We know like there is a network of again azygous system of vein and left gastric vein, which is forming a network at esophagus. So suppose again if there is a portal hypertension, these blood vessels may rupture and patient may come to us with blood vomiting. That condition is called as esophageal varices. That means the porta-caval anastomosis at esophagus is rupturing and the patient is presenting with blood vomiting. You call that condition as esophageal varices. Esophageal varices. Okay. So rectum anal canal also we saw porta-caval anastomosis is there. Again in case of portal hypertension, if these blood vessels are rupturing, patient will present with piles. Okay, that is bleeding. The piles and hemorrhoids we did when we were doing rectum anal canal as well. Same thing here because of now you are knowing the cause due to one of the reason is constipation. The other reason can be portal hypertension also. So in case of portal hypertension, these blood vessels will rupture and there will be bleeding through rectum and anal canal. Okay. So that is hemorrhoids. All these are not required to do. So there may be ascites also. Ascites, that means when in case of liver failure, there will be accumulation of blood in the abdominal cavity. So you call this condition as ascites. Okay. Just a minute. So you can see the condition ascites here. So ascites is also occurring due to liver failure. Okay. So when the abdomen is fully distended and it is filled with fluid, that condition is ascites. This occurs due to liver failure, where liver is not in the position to produce plasma proteins like albumin. Then you will see collection of fluid in the abdomen. Okay, that is ascites. So that is all about portal vein, beta. So till I take you to the other answer, meanwhile you try to read the other. See here. So when you see the spleen, so first thing you have to draw is it has outermost covering which is capsule. Okay. So then inside the spleen you have to draw red pulp and white pulp. Now what is the difference between red pulp and white pulp is, so in case of white pulp you have to draw all lymphocytes. It is all made up of lymphocytes. Okay. And the artery will be basically pushed to one corner. You call it as eccentric arteriole. In some books, it's given as central arteriole also. So you draw the artery towards one corner and draw full lymphocytes, blue in color. And peripheral lymphocyte should be darker and central lymphocyte should be paler. And between this white pulp and white pulp, you are supposed to draw all red dots. Those are actually representing blue and red. That means combination of lymphocytes, RBCs you will find. Okay. So that is one picture of spleen. See here, this is exclusively white pulp only you are finding. I told you peripheral lymphocytes I want you to draw darker, central lymphocytes paler, because that is the place where lymphocytes are maturing. It is called a germinal center, and you will see the artery will be pushed to one periphery, that is the eccentric arteriole, and in between you just try to put pink dots. Those are RBCs. So that's what is about spleen. It has alternating red and white pulps. Okay. You can check the things from your textbook also. So this is better picture, better. So the splenic artery is actually entering at the hilum. You are finding like outside is capsule. Then you draw in between areas are red pulps, and whatever bluish areas are seen, those are white pulps. Okay. So then, so whatever histology book you are following, you can follow, draw a well-labeled diagram. And below the diagram, usually one box with few points will be given. You learn those points. That is enough. Okay. Okay, retinacula around flexor retinacula of hand is asked. Okay. Chorionic villi. That's okay. Are you able to see the blood supply of long bone picture on the screen?
Long one. Yes, ma'am.
Thank you, beta. Now see here, if blood supply of long bone question is asked, what should we write? See, from the there in any long bone we have nutrient foramen. From the nutrient foramen, you will see the nutrient artery is entering. Okay, this nutrient artery will give one branch which is moving upwards and one branch which is moving downwards. Okay, so and then I told you here we have the epiphyseal cartilage, and the junction of the diaphysis and epiphysis is metaphysis. So at the point of metaphysis you will find hairpin bends. Okay, those are metaphyseal arteries. Okay, so then you have to show few branches coming from outside also. Like for example, we did anastomosis around elbow joint. So suppose if it is elbow joint, you will have so many arteries coming from the branches of brachial artery, radial and ulnar arteries. That means these arteries are coming from outside and supplying the bone towards the ends, and towards the like shaft you find nutrient arteries entering and which is supplying inside the bone. Okay. So that is one picture you can draw for blood supply of long bone. This is much better picture, beta. So I want everybody to learn this picture. So blood supply, you have nutrient artery entering practice this picture only, then you have one branch going up, one branch coming down. You are finding at the metaphysis, the metaphyseal arteries which are hairpin bends. There is a risk of infection because you will have hairpin bends like area over here. Then from outside we have epiphyseal arteries coming, and then of course there will be anastomosis of the nutrient artery with the arteries coming outside. So draw this picture and then you can give your explanation which is given in general anatomy book. Okay, this picture is much better. Follow this. Nutrient artery, the arteries which are supplying outside, these are periosteal arteries. At the metaphysis we have metaphyseal arteries which form hairpin bends. Okay, then from outside we have epiphyseal arteries, and it is clearly written here anastomosis between epiphyseal and metaphyseal arteries after epiphyseal fusion. If you draw this well labeled diagram and write the points in your own words also, it is more than enough. This picture is very good. You can take the photograph of this picture. Okay. Now let me take you to the flexor retinaculum of hand. So do you remember what are the names of the bones we have in the carpels? There is a code for it, right? She looks too pretty, try to catch her. What does it? Can you give me the full form? Scaphoid, lunate, triquetral, pisiform, trapezium, trapezoid, capitate, hamate. Isn't it? These are the bones which are seen in the carpal region. Now I am talking about these bones because see here, in the flexor retinaculum, you will see like first of all we should know the attachments. So whatever I said, scaphoid, lunate, triquetral, pisiform, so these are proximal bones. Okay, then trapezium, trapezoid, capitate, hamate, these are distal bones. So let me show and discuss so that you will understand. So are you finding the picture on the screen? Flexor retinaculum.
Ma'am.
See here, the flexor retinaculum towards the thumb. You have to remember pH. Scaphoid. No, beta. ST you have to remember. ST means scaphoid and trapezium are the two bones which are giving attachment to the lateral aspect of flexor retinaculum. Okay. Little finger is medial. Here you remember pH. That means pisiform and hamate. Pisiform and hamate are the two bones to which flexor retinaculum is attached medially. Okay. STPH. Okay. So ST is scaphoid and trapezium. PH is pisiform and hamate. So these are the attachment of bones which the flexor retinaculum is taking. So you can see few structures are passing deep to the retinaculum and few structures will be passing superficial to the retinaculum. So let me show you this picture. See, this picture is little more clear, right? So here you will have, so towards the thumb we have scaphoid and trapezium, and towards the little finger we have pisiform and hamate. So you are finding many structures are passing deep to the retinaculum. So what are these structures? We are finding the tendons, long flexor tendons, the names of the muscles what we have studied in median nerve. Those muscles you should remember now. Flexor digitorum profundus, flexor digitorum superficialis, then flexor pollicis longus. Okay, and we will